silêncio agora durante a próxima palestra. E, gente, tem gente que entrou sem assinar a lista, tá? Não esqueçam de fazer a credencial lá atrás depois. Seguindo o nosso cronograma, nosso próximo palestrante, graduado em Medicina pela Johns Hopkins University School of Medicine, residência em Cirurgia Ortopédica do Johns Hopkins, um fellowship pela University of Miami School of Medicine em 1993, professor em Neurocirurgia e Cirurgia Ortopédica do Johns Hopkins, além de atuar como chefe do departamento de coluna e vice-diretor de operações clínicas desse mesmo hospital. Autor e coautor de mais de 100 artigos e publicações científicas. Dr. Lee Riley, uma salva de palmas. Dr. Riley,
Well, thank you. It's a great honor for me to be invited here and to talk to you and interact with you. And thank you very much for inviting me. Okay, I'm going to talk up here. Okay, great. So this is a picture of the dome, which is the original building at Johns Hopkins. And hopefully I will show you some other pictures of the campus at my next talk. I'm going to talk to you about cervical spondylotic myelopathy. Those are my disclosures. The cervical myelopathy is a clinical syndrome due to arthritis of the spine, and it causes spinal cord dysfunction. The symptoms are relatively subtle, and they're often missed, and the diagnosis is late. So the symptoms are problems with balance, dexterity of the hands, changes in writing, and numbness and tingling in either the hands or the feet. In severe instances, patients can have a burning sensation in their arms or legs or their chest, problems with incontinence, problems with paralysis. They can develop paralysis late. There are multiple causes of this condition, anywhere from degenerative changes to instability to kyphosis to a variety of different types of conditions that can cause this. So it can be due to decreased canal size causing spinal cord compression, changes in spinal alignment such as kyphosis, hypermobility or excessive mobility of the spine, or vascular compromise to the blood supply to the spine. Canal stenosis is from multiple causes. There could be a congenital cause. There could be arthritic changes in the spine. And then there could be a condition called ossification of the posterior longitudinal ligament, which is an inflammatory condition that can cause bone formation, putting pressure on the spinal canal. Spondylosis is due to disc degeneration, and that typically occurs first here, disc degeneration, leading to osteophyte formation, thickening of the ligamentum flavum, and hypertrophy of the facet joints. So there's a combination of different types of arthritis that leads to compression of the spinal cord. Kyphosis, or forward bending of the spine, can cause compression of the spinal cord and draping or compression of the spinal cord over over discs and other types of osteophytes. There can be a pincer effect where there's thickening and buckling of the ligaments and disc bulging that can lead to spinal cord injuries as well. Hypermobility is another cause. Greater than 3 millimeters of motion and repetitive cord trauma can lead to spinal cord injuries. The natural history of this condition has been studied extensively. In this paper, they looked at about 120 patients over several years. And what they found was that most people declined, or their symptoms increased over time, And they did it in a sudden fashion, so a stepwise fashion, so that most people had worsening in an unpredictable and dramatic way. This is another, and again found that this sudden deterioration, and that over 10 years, most people with this condition, if left untreated, were severely disabled. Again, most of the natural history papers demonstrate that the symptoms will become severe, with very few people having improvement over time without treatment. This is an example of a classification system for myelopathy. It was developed by the Japanese, and it looks at both hand function and walking ability. It also looks at sphincter function, and these are the three major areas that are affected by this condition. So how do you diagnose this condition? What are the steps that you take to make the diagnosis? So plain radiographs are useful in looking at the overall alignment of the patient. They give you a sense of whether there's any instability if you get flexion and extension x-rays. But they are poorly correlated with other aspects of the condition in patients under 40 years old. So you need other studies to make the diagnosis. MRI is the imaging study of choice. It will show you the location and the extent of the compression of the spinal cord. It will give you a sense of whether there are any lesions internal to the spinal cord, and it will, and that can be useful in determining the prognosis of the patient with treatment. It is not good at looking at bone, and is not good at distinguishing between bone and discs. So osteophytes, stenosis are not clearly imaged. For that reason, you need often to get a CAT scan. This is a study looking at the use of MRI scans in predicting the outcome of patients with surgery. What this study found was that if patients had lesions such as this in their spinal cord, that they did better than patients who had lesions such as this and this in their spinal cord. So the types and character of the lesions were useful in predicting the outcome of the patient after surgery. This is another that looked at not only the lesions before the surgery, but the lesions in the spinal cord before and after the surgery. What they found was that if the spinal cord lesion improved after the surgery, that patient was more likely to have a better result. If the spinal cord lesion, such as this one, persisted after the operation, so this is a cyst in the spinal cord, this patient was likely not to do as well. So an MRI scan, the characteristics of clinical MRI scans can be used to predict an outcome of a patient after surgery. And also allow you to counsel patients before surgery as to the likelihood of their improvement. So in summary, MRI scans are a gross indicator of the underlying pathology. T2 weighted images give you a broad sense of that there is a problem with the spinal cord. A T1 lesion, which is a different type of setting for the MRI, it shows irreversible damage. This is a CT. This is a CT of a patient with spinal cord compression. You can see here that it is very good at looking at bone spurs and narrowing of the foramen over multiple levels. So what's the overall outcome of patients when they're treated with surgery versus non-surgery? Again, patients not treated tend to have progressive worsening of their symptoms. They have decline in their ability to function, and the operative group tends to have better neurologic improvement and overall better function. So neurologic improvement with surgery is likely. It prevents further deterioration. The best results are done if it's performed within 6 months to a year of the onset of their symptoms. The surgical goals are to decompress the spinal canal, to preserve or restore the alignment of the spine, and to preserve or restore mechanical stability. There are 3 different options for surgery. You can operate from the front, you can operate from the back, or you can operate from the front and the back. There are some instances where you operate from the back, then the front, and then the back. So there's different types of options depending on the clinical problem that you're trying to solve. This is an anterior approach, so an approach from the front can be used in 1 to 3 levels. And when I mean a level, I mean a disc space. So this would be considered 2 levels. You can either do a discectomy, where you just remove the disc and the surrounding bone. You can do a corpectomy, which can be useful if there's compression in areas other than the level of the disc space. This patient had a corpectomy where we removed the discs, the bone spurs, and the vertebral body. And you can see here the remaining changes in the spinal cord after the operation. Anterior approaches, there is controversy as to how to, with the treatment. The controversies are whether you should remove the bone spurs or not, whether you should remove just the disc or the vertebral body, and what type of instrumentation, what types of plates or screws that you should use. In an early study by Henry Bowman, who's one of the founders of cervical spine surgery, he found that removing the osteophytes did not affect the patient's ability to improve. However, another surgeon found that removal was useful and led to improvement in all patients. I tend to remove the bone spurs thinking that pressure on the spinal cord is bad, and if I can remove it, the patient will likely do better. So there's also a controversy about whether to do multiple levels of a discectomy, removing the disc alone, or removing the vertebral body. So discectomies are better at improving the overall alignment of the spine to restore a normal curve or lordosis of the spine. It gives you more points to put screws when you're using a plate and screws. It's very good for disc level compression, but there's a higher rate of the bones not healing, a non-union. A corpectomy, which is removal of the entire vertebral body, allows you more extensive decompression and safer, often, decompression of the cervical spine. It gives you a lot of bone graft to use to reconstruct the defect that you've created, but there can be graft dislodgement and plate failure, especially if you do more than one level. So there's a lot of stress on the implant and the reconstruction. And it may require a posterior operation to get secure fixation and everything to heal. So the fusion rates for a one-level anterior cervical discectomy and fusion is 95%. At two-level is 82%. But if you do a corpectomy such as this is removal of of the vertebral body, the fusion rate is restored to about 90%. So it's a higher fusion rate with corpectomy. So there's also different types of plates. Some plates are rigid and don't move. Other ones move and are what are called dynamic plates. These plates are very useful with multiple level corpectomies and load the graft and create a better, more stable construct. There's also a hybrid where you do both a discectomy and then also a corpectomy. Here, this patient had a corpectomy here and here, but we left the vertebral body here, and so this is what's considered a hybrid. They give you more points of fixation for your screws, and it's a more stable construct, more stable reconstruction. There's also circumferential fusions. This is used for more than 3 levels. It's in patients who have poor healing because they have other medical conditions that will impair healing, such as diabetes or renal failure or poor nutrition. It can be useful in addressing congenital stenosis, so you do a decompression from the back, or also with kyphosis, so when you have to restore the normal alignment of the spine. There's several complications with this type of procedure. The esophagus can be perforated. You can have problems with swallowing or hoarseness. You can have damage to the vertebral arteries or other blood vessels in the neck. And then you can have airway obstruction from swelling after the surgery. You can imagine there's a lot of swelling after this type of surgery, the more levels that you do. So airway obstruction is something that occurs and is found to be more likely if you operate longer than 2.5 hours. If the patient has a difficult airway, a very small airway, then you're at a higher risk of this problem after about 1.5 hours of surgery. And often an anesthesiologist will do a cuff leak test. They will drop the balloon with the endotracheal tube to make sure that there's air that's passing by the tube before they remove it. And that can be something that can be done to determine whether you remove the breathing tube or not, or whether you leave it in overnight until the swelling improves. This is a study that I did with the Cervical Spine Research Society that showed that swallowing problems increase with the number of levels that you do. And there's up to about a 35% permanent swallowing changes in patients who have more than 2 or 3 levels done. So again, the anterior approach, the limitations are swallowing problems, problems with the bones not healing or the hardware failing. Alignment restoration can be difficult with multiple levels, and you really cannot do more than 3 levels. So there's problems in treating more than 3 levels of disease. For that reason, there are posterior approaches. The posterior approach is good for more than 3 levels of disease. when patients who have cervical lordosis that's normal or neutral. So if someone has a neutral alignment but not a forward flexion. You can do a laminectomy, which is removing of the roof posteriorly. A laminectomy and fusion, which is removing the roof and putting screws and rods in. And then something called a laminoplasty, which is cracking the roof and preserving it. So a laminectomy, which is this, where you've removed the roof, you've removed the lamina, gives you excellent visualization of the spinal cord and nerve roots. It's good with, in patients with lordosis and no instability. The outcome of laminectomy alone is good initially. 75% of patients will have improvement, but there's deterioration late. So after several years, patients will have their symptoms return or progress. The causes of this are multiple factors. There can felt to be the fusion membrane, progression of arthritis, and that can then lead to kyphosis and instability. In most instances, there's progression because you've lost all of the stabilizing structures, the ligaments and bones in the back that holds your neck upright. So, again, these are the reasons for a kyphosis. So the effect of a laminectomy has been found to put greater tension on the facet joints in the back of the neck. It increases stress on the spinal bodies and can cause bone spurs and wedges. And you lose the center of gravity moves forward, and you develop kyphosis. This is a study of the effect of doing what's called a facetectomy, which is just making a little window over the nerve root and removing part of the facet joint. They found that less than 25% at two levels, or less or greater than 50% at one level, led to kyphosis and instability. So laminectomies, again, have a good results initially, but because of the instability that it creates, it's not a durable, long-lasting result. So in response to that, surgeons initially developed laminectomies and fusions with bone graft. So they would put the bone that they removed back in and allow it to heal. And they found that there was better results with this than with just a laminectomy alone. However, the results were not as good as they had hoped. For that reason, people began to use screws and rods to act as an internal brace, to hold the neck still and in the position that you wanted it to heal. So you would put the screws and rods in, and then the bone graft. They found that there was a low complication rate with no deterioration over time. Okay, this is, again, been proven by multiple studies. So the posterior laminectomy and instrumented fusion avoids an anterior approach. It is extensile, but it has some complications related to it in terms of the non-union, but it's a very useful tool for both this condition as well as trauma. There's another type of operation called a laminoplasty, which does not involve a fusion. What it involves is preserving the lamina but rotating it away from the spinal cord and giving the spinal cord more space. It allows motion and prevents the post-laminectomy instability, the loss of the alignment. This is how it's done. Here is the spine. You make a little notch on the side of the lamina. You cut the other side of the lamina, and you rotate the lamina away from the cord. And the spinal cord is given more room. It's good for patients who have a normal alignment or a straight alignment of their spine. What's been found with this is it's very good in preserving neurologic recovery and maintaining it over time. Patients do have some neck pain associated with the operation afterwards. There is some loss of neck motion, but you have greater neck motion than you would otherwise with a fusion. Complications can be a nerve palsy, so you will lose function of your arm, especially your deltoid, so you can't raise your arm. It typically resolves over about 3 to 6 months, but requires physical therapy to keep the shoulder from being stiff. So laminoplasties, this other operation, has poor outcomes if you have kyphosis or forward bending of your spine. If there is cord atrophy, in other words, if the spinal cord itself is already damaged. If your symptoms have been of very long duration. If you are older, so if you're over 65 or 70, you're less likely to show improvement. If there's severe cord compression, or if there's associated radiculopathy. All of those things, again, showing signs of a very long-standing condition. There have been comparative studies of all of these to look and see which one is best, both looking at their sagittal alignment, their overall alignment, their neurologic improvement, and their complications. I'm going to review those studies with you. So this is a Japanese study looking at laminectomy, removing the lamina, versus laminoplasty, rotating the lamina. And what they found was that 33% of patients with laminectomy had problems with their lordosis, with their alignment, whereas only 6% of the laminoplasty group had changes in their alignment. So the laminoplasty group did better in the long term with alignment. This is another study looking at laminectomy versus a corpectomy versus an anterior cervical discectomy and fusion. What they found was that the corpectomies had a better improvement than either the laminectomy or the anterior cervical discectomy in this study. So if you look at laminoplasty versus a corpectomy, they had the identical recovery rate, but the corpectomy had a higher complication rate than the laminoplasty. So a laminoplasty was better than a corpectomy, removing part of the vertebral body. So the treatment principles for this condition are that you want to take the pressure off of the spinal cord and the nerve roots. You want to either recreate and restore or preserve the spinal alignment. And you want to make sure that what you've done that you create stability of the spine. You preserve or create stability of the spine. For 1 or 2 level disease, for 1 or 2 levels involvement, an anterior approach is generally better. It's a better neurologic outcome and a low complication rate. Greater than 3 level disease, it depends on the alignment of the spine. And the posterior is typically best, and it's better because of the complications associated with an anterior approach over multiple levels. The swallowing problems, the non-union, the voice changes, those types of complications are higher with the more levels you do in the neck. So I'm going to give you an example of a patient with this problem. This is a gentleman who is 28, and he has cerebral palsy from birth, and he has athetoid CP. So what that means is he's constantly moving his neck back and forth. And he developed sudden weakness, problems with his walking, so he was falling, and his hand function declined. He was working full-time, assembling parts in a factory. He had developed sudden weakness in his arms, in the deltoid, so he couldn't raise his shoulders. This are his x-rays. You can see that he has a lot of arthritis in his neck, and that his neck is in kyphosis, meaning it's bent forward. That's what it looks like when he tries to straighten his neck. This is what his MRI scan looked like. So he had multiple areas of arthritis, and this is an intrinsic cord lesion. This is an injury to the spinal cord. You can see here, here, and here. These are all areas of compression with intrinsic cord lesions. So he underwent both an anterior and posterior operation. An anterior operation to correct and restore his lordosis. Then a posterior instrumentation and fusion to preserve his alignment and create stability. So what's the future of this type of condition? What opportunities do we have to do better as surgeons and physicians? Now, we've looked at MRI scans and their ability to look at images and to look at the spinal cord and the discs. But there's another thing that MRI scans can do, and it's to look at different content of the spinal cord itself. So you can look at different metabolic and cellular information of the spinal cord. And this is a study that looked at 21 patients with and 13 patients without spinal cord injuries from myelopathy. They looked at the N-acetyl-aspartate, choline, lactate, and creatinine content of the spinal cord. So this is an MRI scan that just looks at the metabolic and components of the spinal cord in that area. What they found was that a lower ratio was consistent with an axonal and neuronal loss. So this was a way of predicting whether someone had already a significant injury to their spinal cord. And it also that a lac peak showed ischemia in the spinal cord. There's another way to look at called diffusion-weighted imaging, and this is another way of looking at the fusion, basically the blood supply and health of the spinal cord. And what they found was that it was useful in predicting the blood supply and the viability of the spinal cord. Most of these types of techniques are first used and widely clinically used in the brain for strokes and tumors. But as the technology in MRI scans improves, the speed and strength of the magnets improves, you're able to look at a smaller structure such as the spinal cord and use the same techniques in the spinal cord as have been used in the brain. So perfusion-weighted imaging looks at regional blood flow changes. They looked at 14 patients pre and post-op. What they found was that improvement is correlated with a better post-op improvement. So in conclusions, myelopathy is a clinical entity with multiple causes. The canal size, the location of the compression, spinal alignment, and spinal mobility are very important. in its treatment and evaluation. The basic treatment involves taking pressure off the spinal cord, preserving or restoring the spinal alignment, and maintaining or creating stability. The future is for earlier diagnosis, for characterization of the condition more specifically, to allow you to decide when and how to operate, and give advice to the patient about what to expect after the operation. There's also active work in looking at nerve regeneration with techniques such as stem cells, growth factors, and matrix, but these are still in the very early and experimental phase. Thank you.
Dr. Riley, speaking on behalf of AEMED, I'd like to thank you for your availability and would like to invite you to accept our souvenir of our Congress. Wesley?
Thank you. Thank you.
Pessoal, antes da nossa próxima palestra, a gente vai abrir o tempo para perguntas. Nosso bloco de ortopedia e neurocirurgia. Alguém tem alguma pergunta?
Sobre os dois temas, tanto a palestra do Dr. Aleix Petrin quanto a palestra do Dr. Lee Riley, primeiro essa pergunta. A gente resolveu fazer pelo microfone para facilitar, a vez que a gente ficar sorteando igual a gente fez na abertura. Muitas perguntas, é muito importante para essa mesa redonda.
Caso alguém queira fazer pergunta em português, não tem problema também, a gente traduz para ele.
Bom dia. Eu queria fazer uma pergunta, não é tão relacionado a a neurocirurgia e a ortopedia em si. Aí eu queria perguntar para o Dr. Lee Riley como funciona assim a formação na medicina, em residência, especialização nos Estados Unidos, porque assim a gente sabe que é um pouco diferente, né, da maneira que é feita aqui no Brasil, mas a maioria não sabe especificamente assim como que se realiza. E eu gostaria de saber um pouco mais.
Can you all hear me? No? So, our system. Our system is different. So our our students go to college first, go to university first for 4 years.
Nosso sistema é um pouco diferente do nosso acadêmicos de medicina. Eles vão para o college, que é a universidade, curso preparatório antes de entrar na faculdade de medicina.
They study a variety of different types of subjects in university of their choice.
Eles estudam uma variedade muito diferente de assuntos na universidade que eles escolherem.
They have to take a certain number of required courses to apply to medical school.
Ele tem que ter um número certo de horas e de certos cursos que ele tem que aplicar para poder entrar no curso de medicina.
And that would include organic chemistry, physics, math, biology. So there's several required courses.
Isso incluiria física, química orgânica, matemática, a biologia e muitos outros assuntos relacionados à medicina.
I majored in Russian.
Eu fiz a minha universidade em russo.
And I took my other courses for pre-med
E eu tive meus outros cursos para pré-medicina.
You then have to take a national test,
Depois você faz um teste nacional
and then you're scored on that test.
e depois você vai ter um resultado desse teste.
Then you apply to medical school.
Depois de tudo isso, você aplica para tentar entrar numa faculdade de medicina.
After you've graduated from college, from university.
Depois que você já tem uma graduação do college, da universidade.
Now, right now in the United States, and if you look at Hopkins, most students who are going to medical school have done something else after college before they apply.
Tanto até se você olhar para o próprio Hopkins hoje, a maioria dos estudantes, eles além do college, fizeram outra coisa depois da universidade para poder entrar e se diferenciar para entrar na faculdade de medicina.
So that they'll do that for 2 or 3 years,
Então eles fazem isso por mais 2 ou 3 anos depois da universidade.
and sometimes longer.
E algumas vezes até mais.
The average age
A idade média
of our applicants
de quem tenta entrar na faculdade de medicina do Hopkins
is 28.
é 28 anos.
So they have spent time as being nurses,
Então eles já tiveram tempo como enfermeiras ou enfermeiros,
physical therapists,
fisioterapeutas,
teachers,
professores,
businessmen,
até empresários.
and so many people, at least in the United States, have decided to do other things before they go into
Então,
medicine.
muitas pessoas, principalmente nos Estados Unidos, decidiram fazer outras coisas antes de entrar na faculdade de medicina.
Others have decided too late in their university that they want to go to into medicine, so have to take additional courses, additional studies for about 2 years before they can apply.
Outras pessoas, eles já estavam na faculdade, mas decidiram muito tarde que queriam entrar na faculdade de medicina. Então, eles têm que fazer um curso de aproximadamente 2 anos para tentar entrar na faculdade.
After you get into medical school, the medical school itself is 4 years.
Depois que você entra na faculdade de medicina, depois de passar por tudo isso, a faculdade de medicina são mais 4 anos.
The first year
Primeiro ano
is spent doing some classwork,
gasto em sala de aula,
such as anatomy,
uma anatomia,
physiology,
fisiologia,
but then also you rapidly are learning how to do clinical skills, how to interview patients.
Então, com o passar do tempo, além dessas matérias, você já aprende a fazer o exame clínico, a fazer a anamnese,
How to do physical exams.
o exame físico.
And basically the last 2.5 years you spend doing rotations in the hospital.
Nos últimos 2 anos e meio, você basicamente fica rodando em áreas específicas dentro do hospital.
At Hopkins, you are divided into several different advisories.
No Hopkins, você é dividido entre vários diferentes conselheiros, diferentes tutores.
Where there are people like me who you meet with on a regular basis.
Existem pessoas como eu que você vai se encontrar de maneira regular
To talk about what it's like to be a physician,
para falar sobre o que é ser um médico,
talk about ethics of medicine,
falar sobre ética médica,
how to manage your time,
como fazer uma administração melhor do seu tempo
and what different specialties you're like.
e que diferentes especialidades você gostaria de fazer.
After medical school, people will go to a residency
Depois da faculdade de medicina, as pessoas vão passar por uma residência
that will be between 2 and 6 or 7 years in length,
que vai ser entre 2 a 7 anos de duração,
sometimes longer,
às vezes até mais,
for things like vascular surgery or neurosurgery.
como por exemplo as especialidades de cirurgia vascular e neurocirurgia.
After that, many people will then do a fellowship,
Depois disso, muitas pessoas vão fazer um fellowship, um estágio,
which would be 1 or 2 years,
que seria mais 1 ou 2 anos,
depending on the specialty.
dependendo da especialidade que você escolher.
And then you start your job.
Depois você começa a trabalhar.
Mais alguma pergunta?
Lucas Cantão.
Bom dia, meu nome é Lucas Cantão. Eu queria saber como funciona para um brasileiro se especializar nos Estados Unidos, como funciona essa burocracia e tudo.
So that's a long process.
É um processo muito longo.
What you have to do is to take the USMLE tests.
Você tem que fazer o teste USMLE, que seria United States Medical,
Licensing examination.
e o exame de licença médica dos Estados Unidos.
Okay. Those are all in English, and there's two different levels of test. There's a basic science test, and then there's a clinical test.
Então são duas fases desse teste, são todos em inglês. A primeira fase é uma fase básica, e a segunda fase é uma fase clínica.
And they're all in English.
São todos em inglês.
So, and then typically the students will try to work first as doing research in an academic center.
Normalmente os estudantes eles vão procurar fazer pesquisa em um centro acadêmico antes.
To get recommendations and get familiar with the system.
Para se familiarizar mais para se familiarizar melhor com o sistema e também conseguir as cartas de recomendação.
And then apply. It's very difficult to get into the United States system. One of the reasons is that when you are trying to evaluate someone,
é muito difícil entrar no sistema, principalmente quando você está querendo avaliar alguém.
It's hard to compare the training in another country to the training in the United States.
É muito difícil você comparar o treinamento que os estudantes recebem em outro país com o treinamento que é recebido nos Estados Unidos.
So that's what makes it so difficult.
Então é por isso que é muito difícil.
Many people try and spend a lot of time trying to do that.
As pessoas tentam e realmente gastam muito tempo tentando fazer isso.
Okay.
Mais alguma pergunta? Só essa gente que está trocando as pilhas no microfone.
And then start over again.
Isso é muito difícil, porque você tem que começar tudo de novo, a residência, a especialidade.
And actually all those other.
Depois de ter todas as outras requerimentos necessários.
Bom dia. First of all, thank you for your presentation. As complicações das cirurgias. Então, sobre dificuldade de engolir, toda essa... Existe, possivelmente, a necessidade de trocar depois todos aqueles... Eu não sou da área médica, mas todos aqueles ganchinhos lá, você me ajuda aí, por favor. Tá? Existe essa possibilidade de ter que trocar para melhorar a qualidade de vida do paciente posteriormente?
Trabalhos, entanto, que mostram que se você adicionar uma placa
to the front of the neck,
para a parte anterior do pescoço,
if you can avoid that, that is better.
se você conseguir evitar isso, é melhor.
So the example that I showed of the patient that I operated on, there was not a plate in the front.
Então, aquele exemplo que eu mostrei da paciente que eu operei, não havia uma placa na frente.
And the reason was because I was worried about the swallowing.
A razão que eu fiz isso porque eu estava preocupada com a questão de deglutição.
And felt that the plate would add extra complications.
Eu senti que adicionar uma placa iria adicionar outras complicações maiores.
Having said that, that particular patient, because of their athetoid CP,
Dito isso, aquele paciente com paralisia cerebral tetoide,
because I did so many levels in the front,
porque eu fiz muitos níveis anteriormente,
because I dramatically changed the position and shape of their neck,
eu mudei drasticamente a posição e a forma do pescoço,
had a feeding tube for 3 months.
teve uma nutrição parenteral por 3 meses.
Só mais uma coisa. Eu sou da área da imunologia e minha preocupação sempre é em relação ao processo, né, constante pró-inflamatório. Aí eu vi ali, né, o futuro, né, células tronco, isso muito me interessa. Então gostaria se eu pudesse falar um pouquinho mais sobre isso, principalmente para os nossos alunos. Obrigada.
Okay. So, there's several different challenges with this sort of surgery.
Existem muitos desafios com esse tipo de cirurgia.
One is the inflammation generated by the acute inflammation generated by the surgery itself.
Bom, a primeira é a inflamação, a resposta inflamatória aguda gerada pela própria cirurgia.
Then there is also the long-term or longer-term issues of malnutrition.
Agora existem alguns problemas de duração maior, como por exemplo má nutrição.
And its effect on healing.
Isso afeta muito na cicatrização e na cura.
Yeah. So there is acute inflammation from the approach that will resolve over several days.
Então existe a inflamação aguda pelo próprio processo cirúrgico que vai se resolver em alguns dias.
There's some early or mid-term inflammation that you actually want with the healing process.
Existe até mesmo uma inflamação inicial e de médio prazo que você que é inclusive desejado para o processo de cicatrização.
For the bones. So if you look at bone healing, there's an inflammatory phase due to the injury that you create.
Especialmente nos ossos, existe uma fase inflamatória de cicatrização nos ossos devido à lesão que você proporciona.
And that's important not to suppress, to allow the bones to grow together.
Isso é importante para não suprimir nessa fase de médio prazo para permitir que o próprio osso cicatrize.
Yes, and that lasts for about 6 weeks.
E isso dura aproximadamente 6 semanas.
So, during the operation, I will give a patient with this sort of an operation a bolus of steroids.
Então, durante esse período inicial, vou dar ao paciente muito esteroide.
During the operation.
Durante a própria cirurgia.
And maybe in the first 24 hours if it's an extensive surgery.
E talvez nas primeiras 24 horas de uma cirurgia muito extensiva.
To minimize the acute inflammation.
Para diminuir a inflamação aguda.
I then do not give them any non-steroidal anti-inflammatories after that because I want to keep the mid-inflammation process active.
Depois desse período eu não dou os AINES, principalmente nesse período depois de médio prazo, para poder fazer essa cicatrização.
And try not to use any anti-inflammatories or some of the anti-inflammatory rheumatologic medications if they have rheumatoid arthritis or some kind of a systemic condition for about 3 months.
E pedir os pacientes não utilizarem os anti-inflamatórios, especialmente os anti-inflamatórios para reumatismos, nos primeiros 3 meses.
And at least 6 weeks.
E pelo menos 6 semanas.
And then we'll really maximize their nutrition in the acute recovery. And if they have swallowing issues, feeding issues, I'll put in feeding to them.
E se você tentar maximizar a nutrição do paciente, principalmente na maneira inicial, para ajudar nessa recuperação, na cura, e se o paciente tiver algum problema de deglutição devido à cirurgia, usar uma nutrição parenteral.
Thank you very much.
Nós não teremos mais tempo para perguntas. Talvez é tudo seu aí, Douglas.
A gente vai encerrar agora a mesa redonda do Dr. Riley e Dr. Aleixo. E o copo está liberado. Uma salva de palmas, por favor. Muito obrigado.